Just 1 minute. Let me do just something very quickly because I think okay, because I will be seeing it here. Yeah, just close the chat because it's very small in my screen. Sorry. Just let me open it. Oh, okay. Okay, now it's fine.
Okay, all good. Yeah, and you can wait a few seconds because it takes a while for people to join.
Okay, when you want to start, just let me know.
Yeah, if you just give it 30 seconds, Zoom
Okay,
is slowly letting people in.
okay.
Yeah, so we've got 500 now, so you
A
can
lot
probably
of
start.
people. Yeah, wow. I'm amazed.
Okay, off you go.
Yeah, can we start?
Yes.
Yes, okay. Hello everybody. We are starting the Climate and Health Medicine Clinical Training Program for Healthcare Educators with session 5, Pharmacology. I would like to first present myself. My name is Ana Abreu. I am a professor of cardiology and preventive medicine at the School of Medicine of the University of Lisbon. And I'm running a department of environmental health and also of preventive medicine. At the same time, I am actually the president of the European Association of Preventive Cardiology. So, my main task is really prevention, health promotion, and at the same time, environmental health. So let's start with our presentation. For English caption, click the CC button on the bottom of the Zoom window. And I would like to remind you the course objectives. First one, to build climate health literacy. We want to develop comprehensive understanding of how climate change affects human health through direct and indirect pathways and the disproportionate impacts on vulnerable populations, which is really very important. Second, to equip faculty with strategies for advocacy to influence governance toward avoiding the health impacts of climate change through mitigation, so halting climate change. Third one, to integrate climate considerations into clinical practice, acquire skills to incorporate climate risk assessment, climate sensitive disease recognition, and climate informed treatment decisions into routine patient care. Fourth, to strengthen healthcare systems resilience, learn strategies for healthcare facility adaptation, emergency preparedness, and maintaining continuity of care during climate-related disruptions. And the fifth is to advance sustainable healthcare practices, implement evidence-based approaches to reduce healthcare environment footprint while improving patient care and promoting health equity. The course schedule is what you see here. So we are in March 31st on section 5, Pharmacology, and then you'll have the part 2, which will be the specialty specific sessions that go from April 7 to May 12. To register for part 2, you have to do it. You must register separately for part 2 for the sessions 6 to 16. So, session learning objectives will be identify climate factors that reduce the potency, shelf life, or other factors that affect the efficacy of medications. Demonstrate awareness of the impact of pharmacological substances on the natural environment and how to reduce adverse effects. Describe how extreme weather events, particularly heat, can impact the effect of medications on patients' bodies and identify what adjustments may need to be made. Develop strategies for counseling patients and patients' caregivers on what actions they may need to take for different climate scenarios in regards to various classes of medications. We have a lot: diuretics, antibiotics, psychotropic medications, insulin, and much more. And also to discuss how disruptions in access to medication impacts patients' health and what steps can be taken to minimize these disruptions for different climate scenarios. So this is a 90-minute session. It will include expert lectures and case studies presentations. Sessions will culminate with question and answer section, where we hope you'll be active. So please enter your questions for the presenters in the Q&A box. Sessions video recording, slide decks, and resources will be made available on the course website. So, regarding attendance, attendance is automatically recorded during the live Zoom sessions. Your individual attendance is only counted if you join using your personal Zoom link. Your attendance is not counted if you join with a colleague's link, and YouTube views will not count towards attendance. Regarding the certificate of participation, participants who attend at least 4 out of the 5 sessions in part 1 and at least 1 session in part 2 and pass the final exam with a score equal or greater than 70% at the end of the course will be awarded a certificate of participation in climate and health for the GCCHE. Note, this certificate is only available for people who use the same email for registration for all Zoom sessions and for exam. YouTube views do not count towards the attendance requirement. So, final exam. The exam must be completed using the same email address used to attend the Zoom sessions. The exam link will be sent on the final day of class via email and WhatsApp and will close on May 19th at 11:59 p.m. UK time. The format consists in 25 multiple choice true and false questions, and participants should be prepared to take the exam in one sitting. So here is how you can join the course WhatsApp group for updates and informations from the course planning team. So link in the chat. Join ENCH, because ENCH is the European Network on Climate and Health Education and is working in close coordination with the GCCHE as a regional network and aims to equip the next generation of medics with the knowledge and insights to deliver sustainable healthcare practices and support the transition to patient-centric, net zero health systems. Glasgow University is extending an invitation to Europe-based universities to join this network. So now I will present the presenters. We have today 2 great presenters, Professor Hayley Blackburn and Professor Fabrice Neyers. So Professor Hayley Blackburn is an associate professor of pharmacy practice at the University of Montana Skaggs School of Pharmacy, where her research and practice focus on the role of pharmacists and other health professionals in promoting environmentally sustainable and climate resilient healthcare. She is a co-founder of RX for Climate, an international pharmacy network advancing climate smart practice through education and advocacy, and contributes her expertise in climate, health, and sustainability through work with Montana health professionals for a healthy climate, the American Society of Health Systems Pharmacies, the International Pharmaceutical Federation, and the Global Consortium on Climate and Health Education. Professor Fabrice Nayers is full professor at University Bourgogne, Europe, and a researcher at CNRS. He is affiliated with the Health Department, where he is specifically involved in pharmacy training programs. His research focuses on biochemistry, with particular emphasis on the fundamental study of enzymes, their structure-function relationships, and their bioproduction. His work notably explores chemosensory processes and the role of enzymes in flavor perception. He teaches biochemistry and enzymology at undergraduate and graduate levels, with a strong focus on connecting fundamental biochemical principles to applications in health and pharmacy. He's also actively involved in supervising students and contributing to interdisciplinary training at the interface of biology, chemistry, and bioinformatics. So, we are going to start with the presentation of Professor Haley Blackburn. Please, Professor Haley.
Take advantage of the learning Hello everyone, thanks so much for having me. I'm so excited to be a part of this course and so glad to have such a great audience participating in this full series to take advantage of the learning that is a part of this. So this session is session 5, Pharmacology, and I am Haley Blackburn. I'm going to be the one giving you kind of a baseline introduction on medications in a changing climate before we turn it over to several of our speakers for some case studies. So you've spent the last several sessions building the foundations of climate science and health impacts and health system resilience. And so today we're going to zoom into a topic that cuts across all of it, medications. Of course, there are these tools we can't live without. They're critical in clinical care, in working with our patients, and the whole healthcare system. But they're also connected to the climate crisis in ways that every clinician and every educator should understand. We're so used to using medications in our day-to-day practice, in even taking them as patients. We think of them as those products right in front of us, and we don't often think about the global scale of their use. So 414 billion daily doses over the last 5 years, according to 2024 data. And that use doesn't show any indication of stopping. By 2028, it's estimated there will be 814 billion daily doses globally. We often don't think about this global scale, but we often also don't think about the upstream and the downstream. What's happening before those medications get to us and what happens after they leave our possession, that they go out into the patient, they go out into the world. And all of this is really important context as we think about this in a changing climate. Everything that happens upstream and downstream of our most common links to medication use, whether that's in the hospital or in the clinic or in the pharmacy, is part of a set of larger, complicated processes that make up the main activities of the pharmaceutical industry and across the pharmaceutical life cycle. So we're not going to have time in my section today to do a deep dive on any particular component of this system or really do a deep walk into the life cycle of pharmaceuticals, but we're going to touch on many of these things, from production to distribution to medicines use and all of the links to climate change, environmental pollution, and planetary health, to give you just a broad overview. Because of the complexity of global environmental change and the interactions with the complex systems around pharmaceuticals, of course, this is going to be overly simplified to just show a few arrows here back and forth between pharmaceutical use and global environmental change and climate change. Really, there are lots of interconnections or feedback loops or complexities here that are better represented with quite a few more little lines linking it all together. Even this is overly simplified, right? But for the purposes of today, we're going to try to keep it straightforward, just focusing on how pharmaceuticals and medication use affects climate and the global environment, and how climate and environmental change impacts medications, including quality, safety, access, and equity. So first, let's start with how medications impact the environment. And I put here global environmental change because it's not just greenhouse gas emissions. It's also pharmaceutical pollution, it's plastic pollution, it's even things like air pollution or ozone formation or impacts on land use and water use and mineral extraction and more. We're really just going to focus on the first two as being the most commonly discussed topics under pharmaceutical use and its impacts on planetary health. At this point, you're probably familiar with the overall climate impacts of the healthcare system, the fifth largest emitter of greenhouse gases if we were to make healthcare a country. And we know that pharmaceuticals make up a big piece of that, somewhere around 10% of global scope 3 emissions, and even more, between 20 and 30% of the overall carbon footprint of healthcare systems in high-income countries. There are many contributors to this outsized contribution of pharmaceuticals. Complex global supply chains contribute to large scope 3 emissions. We have energy-intensive manufacturing processes, resource extraction for raw materials, including petrochemicals. We have all sorts of cold chain requirements, plastic use, and more. And we often also talk about high carbon pharmaceuticals like anesthetic gases and pressurized metered dose inhalers, with hydrofluoric alkane propellants as major offenders in this picture. All of this is true and can be incredibly detailed if you break it down even further. Pharmaceuticals have a large and growing environmental footprint too. If we look at global trends across the last several decades, from 1995 to 2019, pharmaceutical greenhouse gas emissions grew 77%. Those increases were largely driven by increased drug consumption from the United States and from China. You see China represented in the peach here, and the purple is the United States. Many of the other regions and countries remained relatively stable. This is, changing across economic development, changing disease burden as we see increasing burden of non-communicable disease, increasing pharmaceutical production, and other drivers that actually may or may not contribute to better health outcomes associated with this increased pharmaceutical consumption. Meanwhile, the same picture of inequity in greenhouse gas emissions around the globe plays out in terms of pharmaceutical-associated emissions. So you can see here in this figure that in terms of kilograms of carbon dioxide per capita, Australia and the US are outliers, while other countries that face greater challenges to medication access, plus a disproportionate burden of climate-related impacts on health, have much lower pharmaceutical carbon footprints on a per capita basis. So overall, high-income countries emit anywhere between 9 to 10-fold more per capita when you look at that compared to lower-income countries. And it's not just carbon emissions, like I said. We also have concerns about environmental pollution from pharmaceuticals. There's a recent study that was a sampling of over 1,000 sites across every single continent, looking at all sorts of freshwater sources, and over 25% of the samples from that study found at least one active pharmaceutical ingredient, or API, at concentrations above the levels known to either be at risk to ecosystems, causing some sort of toxicity to the organisms living there, and or at a concentration of concern for selecting for antimicrobial resistance. You can also see here in this figure that countries around the world bear disproportionate burdens of pharmaceutical pollution. The darker the red in this figure indicating a higher mean cumulative pharmaceutical concentration in the samples tested in each country. And some of these differences are due to things like differences in water treatment or waste infrastructure or clinical use patterns or even agricultural use. And this is a complex issue, But some of these outliers have also borne a disproportionate share of pharmaceutical pollution and the downstream consequences because of them being hubs for pharmaceutical manufacturing industry, particularly for generic medications, and the pharmaceutical pollution that arises from those processes. In general, what does pharmaceutical pollution do, and why do we care about it? How do we know that it's bad? Well, this is dependent on a lot of different things. It depends on the drug itself, how toxic it is, how long it hangs out in the environment before it breaks down, how much it bioaccumulates, and what concentration the organisms in the ecosystems are actually exposed to. And we know that a lot of aquatic species experience harm from relatively low levels of exposure to pharmaceuticals in the aquatic environment, including reproductive changes, changes in behavior, neurotoxicity, endocrine dysfunction. The drug classes of concern on the right-hand side of the screen, these are the general classes that we see most commonly being highlighted in the literature as being the ones with the greatest impacts. And these effects don't just play out at an individual level on several different, just a few organisms. They've been shown to have significant population effects and cause widespread harm to ecosystems, because we know that, it's not as if just one aquatic species, one type of fish, one insect, whatever it might be, totally exists in isolation. It's connected across a broad ecosystem. And so when you have these drugs impacting one organism, often there are magnified ripple effects across ecosystems. How about human health? What do we know about that? We know that in general, humans, because of the concentrations of pharmaceuticals in the environment, we generally have low-level exposure, but there's really inadequate data to say if this is safe for certain populations that might be more sensitive, like children or pregnant people. It's also a documented driver of antimicrobial resistance, and something that maybe we don't always appreciate when we think about our antimicrobial stewardship efforts in clinical settings. We don't always remember that we also have antimicrobials in the environment that are working against us as well. And we know that antimicrobial resistance is not just a threat in our own clinics and hospitals, it's a global health threat. We know that pharmaceutical pollution is one important driver here. So if you'll recall that earlier map of the pharmaceutical pollution with the different shades of red, you'll see some similarities in the concentrations of pollution on that prior map and resistance rates that you see here in this global map of resistance of E. coli to fluoroquinolone antibiotics. So I'll call here to your attention specifically India as an outlier here. So there have been some alarming studies out of India looking at the presence of significant quantities of antibiotics, most commonly fluoroquinolones, present in treated wastewater downstream of some big pharmaceutical manufacturing hubs or manufacturing facilities, and really observing high levels of these antibiotics and antimicrobial resistant bacteria in surrounding soil and aquatic samples. These concerns first cropped up about this pollution in the 2000s, 2010s, and there's been incremental change to policy and regulation in this region to help manufacturers move toward compliance and reduce pollution. However, there are still some gaps there, and even more so, these effects remain. A study from just a few years ago showed when they sampled across 6 different states in India, elevated concentrations of antimicrobial residues of 7 different antibiotic classes, high prevalence of antibiotic resistance genes, and strong genetic similarity between sewage-derived strains and clinical pathogens. Bottom line being that this environmental pollution is linked back to the challenges seen in clinical treatment, and that has global consequences for our ability to treat infectious disease. Interestingly, there might also be links between a warming climate, things like heat and drought, and further acceleration of antimicrobial resistance. Just one example of some of the complicated connections between climate, between pollution, planetary health, and the changing clinical challenges we're seeing. All of this is in the context, again, of this complex global supply chain and pharmaceutical industry. Many of our drugs have incredible pathways from their start, from raw materials to reaching the point of use. A study just published in 2025 looked at the journey of a single type of tablet of clonazepam and found that it traveled over 60,000 miles from its origins in manufacture all the way to the point where it reached a Vancouver pharmacy to be handed out for use. So it went from India to the EU, back to India, to the United States, and through several points in Canada before it reached the pharmacy in Vancouver. This is just one example. Many of our generic drugs are this way. We also know that on a global scale, there's a lot of heterogeneity in policy and regulation. There are changing consumption patterns of medications that create more complexity on a global scale. And all of this can feed directly into the challenges faced by clinicians trying to promote sustainable use of pharmaceuticals alongside climate resilience. So while this high-level overview might seem a bit removed from day-to-day practice, I hope it puts the global issues in view and really underscores the importance of urgent action at all levels, including in your clinical practice and in any education efforts that you're taking on. So for the clinicians or clinician educators in the audience, improving the way we use medications in our own systems is a big step forward. And we think about this from an environmental stewardship lens. Often it's not a straightforward approach. It requires something that's very structured. Think about like how we approach antimicrobial stewardship, that stewardship approach with collaboration across many different disciplines, a clear process, and good data to drive things forward. There are many different evidence-based opportunities to reduce the environmental impacts of pharmaceutical use through things like reducing drug waste or promoting IV to oral conversion of certain medications or opting for lower carbon pharmaceutical options when it comes to things like anesthetic gases or inhalers and more. There are lots of different things that we can do. I hope that you'll have the opportunity to learn from some experts in some of the case studies and clinical specialty sections to see some of this in the form of real world examples, because I know that this is very high level systems thinking, discussion at this point. So let's switch gears and look at the other side of this. How does climate impact medication? Specifically, how does it impact the quality, the safety? What sort of drug-environment interactions do we know exist? What about access? What about equity? And how do we need to consider this in clinical practice and in education? Environmental change for us means changing patterns of pharmaceutical use as we have changing demands on healthcare, and that means changing challenges for quality, safety, and health equity. There are a lot of different examples, like under the examples of extreme heat, which we'll get into a little bit later. Everything from medication and device stability, cold chain challenges, medication safety when we think about thermoregulation. I mentioned antimicrobial resistance connections potentially. We have severe weather. We have changing patterns of vector-borne disease that are going to create new challenges for research and development, for pharmaceutical production, surveillance systems, immunization and treatment. Air pollution and wildfire smoke, we have good documentation that increases medication utilization, specifically inhalers, and has other demand for healthcare services that can then, of course, feed back into more issues with pharmaceutical sustainability if we have an uptick in inhaler use. Drought, another one that can impact the pharmaceutical system as we lose availability of water and raw materials for pharmaceutical production. And biodiversity loss, maybe an underappreciated one, as we see a changing climate and environmental change feeding into loss of traditional medicines as a really important source of healthcare for people across large parts of the world, and also loss of sources of new drug discovery, as we often see nature-derived solutions feeding into our pharmaceutical development sector. We know that severe weather and other climate-related events are stressors on our healthcare systems, and this is no different when we look specifically at their impacts on access, quality, and safety of medicines across production, supply chain, pharmacy and clinical operations, and what's happening at the level of patient use. Just a few case studies to illustrate on the left-hand side of the screen. So in 2024, Hurricane Helene hit a manufacturing facility in North Carolina in the southeastern United States. And that facility manufactured over 60% of the country's sterile IV fluids. So as you can imagine, the impacts were widespread and really affected much of day-to-day clinical care as people scrambled to convert products or find what they needed or adapt their clinical strategy to confront the reality of not having the IV fluids they were used to. It also left people across the global supply chain scrambling to secure sterile IV fluids as the demand from the US increased, as we lost that domestic production. So a follow-up study after this event looking at pharmaceutical manufacturing facilities around the United States, found that 2/3 of our active production facilities were located in counties experiencing a climate-related disaster from 2019 to 2024, really highlighting how many of our facilities are potentially vulnerable to climate-related effects and how that might have ripple effects across our access to medications and our clinical care. We don't have good data quantifying something similar on a global scale, but if a tablet of clonazepam needs to travel over 60,000 miles from manufacturing to distribution to reach the point of use, then you can imagine that there are many opportunities for supply chain failure for many critical drugs if severe weather hits at the wrong place and the wrong time. Those disruptions might happen on the other side of the world or just down the road, but either way, they can seriously disrupt access and impact care. And Hurricane Helene wasn't the only disruptive event in recent U.S. history. Just 7 years earlier, in 2017, Hurricane Maria hit Puerto Rico and again caused massive shortages of IV fluid production, as that was another manufacturing hub. And a study of medication errors in the U.S. in the time immediately after, looking just at medication errors related to heparin use, which was a product that had major impacts from that IV fluid shortage. The study found a 150% increase in medication errors during that time. So this isn't just about supply chain and access. This bleeds into the quality and safety of our medication use systems. There are plenty of other studies that illustrate disruptions in access to things like oncology care or other critical treatments that result in delays in care and potential adverse outcomes to overall patient health. We also know that these events have direct impacts on patients and their ability to access, store, and use their medications as directed. So whether it's that their pharmacy is closed or inaccessible due to a washed out bridge or a fire that's burned through, or whether it's a power outage that impacts their ability to refrigerate medications, or an evacuation that leads them to leave their medications behind, or even really just the stress of living through these events. It's difficult to remember to take medications as directed when you're just trying to orient in the context of a disaster. All of these are real consequences we should consider. Often the patients who are going to be most impacted in these scenarios are the ones already bearing inequities and disproportionate consequences of a changing climate, who are now facing additional consequences of their impacts on medication use. So as one good example and an important topic for us to touch on, thinking about how climate might directly impact medication use and safety is looking at the interactions between medications and heat. We know that there are a lot of different pathways by which this occurs. Heat affects medication stability. Heat also affects medication pharmacokinetics. We know that medications can alter thermoregulation and can increase the risk of harm when people are exposed to hot temperatures. And we also know that medications are a cornerstone of clinical management of populations with additional vulnerability during heat exposure, which means that overlap is important for us to consider when we're thinking about clinical adaptations and clinical practice. So let's start with medication and heat stability. We know anecdotally, and studies confirm, that people are not good at consistently storing their medications according to manufacturers' recommendations. There's a recent publication showing that about 1 in 3 people were storing their medications outside of recommended temperature ranges. And this is likely an underestimate. It also doesn't account for storage conditions in transport or delivery, or even storage in clinics or pharmacies where they don't have temperature-controlled areas for that storage. And in a lot of cases, there's surprisingly little data suggesting or looking at the details of medication degradation under hot conditions. Most data suggests that the average tablet or capsule probably is not impacted greatly by exposure to typical elevations in ambient temperatures that you might see during an extreme heat event. But some temperature deviations and types of products are more concerning. Things like refrigerated medications, whether that's insulin or GLP-1 receptor agonists or vaccines, or emergency medications like epinephrine or naloxone, or liquid dosage forms, suspensions, solutions, controlled release systems, topicals. All of those are going to be a little bit more sensitive to heat exposure and the risk of degradation. The primary risks are really reduced potency, treatment failure, altered drug delivery, or accelerated microbial growth under warmer conditions in the case of like sterile products. In some cases, these changes might not be a major concern and might not have significant clinical impacts. In others, we put people at risk of treatment failure during an emergency situation or subtherapeutic doses of antibiotics that might further drive antimicrobial resistance, or loss of effectiveness of vaccines, plus all of the environmental consequences of pharmaceutical waste if we have medications that are damaged by heat and need to be discarded and go unused and unfortunately wasted. We also need to pay attention to the devices we use for delivery or therapeutic monitoring. Examples include pressurized meter dose inhalers, where when they are exposed to heat, they risk malfunction or even bursting. We also dry powder inhalers. There's some concern around exposure to humidity and heat that impacts the way that the powder disperses and gets delivered to the lungs when patients inhale. Also, glucometers and test strips can malfunction and cause clinically significant errors with exposure to high temperatures or improper storage or use. And insulin pumps are another one. There's been some high-profile case studies looking at patients who have left their insulin pumps out to be exposed to extremely hot temperatures and have they're then malfunctioned and caused serious clinical consequences for those patients. So for all of these reasons, paying attention to heat and medication stability, device integrity is something that we should be considering as we are teaching and as we're practicing clinically. The good news is, as I said, generally that mild heat exposure isn't likely to damage most medications short term, but we should still be educating patients and really promoting the best storage possible to avoid exposure to the most extreme temperatures. Medication should be kept out of hot cars or mailboxes and out of the direct sun, as extreme temperatures that we see in those types of scenarios can definitely degrade them. Insulated containers or like bubble wrap mailers, those sorts of things work well. Often it's important to try to strike the right balance of keeping things cool but not freezing them, like not putting them directly on ice to the point where the insulin or the vaccines freeze and then therefore are damaged and are not good for use on the other end of the extreme. Often things like cool gel packs or things like that can be a little bit safer in avoiding that consequence. For things like power outages, patients should also have a storage backup plan, and often keeping things just like cool will be enough to preserve the product integrity and protect it from heat. For instance, there was a Cochrane review of insulin storage that found that insulin maintained acceptable potency when stored out of the sun in clay pots, no active refrigeration when it was used in lower resource settings. So people are often surprised by this, and it isn't by the book in terms of refrigerated directions or a standard recommendation that we would make when refrigeration is available. But I think it does underscore that we need more research in the general area of heat and medication stability so we understand how we can best adapt to warming conditions. Heat can also affect the pharmacokinetics of certain medications. High temperatures, as our body tries to thermoregulate, cause vasodilation. It can result in dehydration. It can cause reduced renal and hepatic perfusion, and it can increase skin blood flow. And as a result of all of these things, you can have altered absorption, distribution, metabolism, and excretion of medications. We can also see reduced renal clearance that can increase the risk of toxicity, especially if it's paired with dehydration. There are certain medications that we might want to think about because of all of these pharmacokinetic changes, or we think about a little bit more as being higher risk. So on the right-hand side of the screen, just a list that might have altered kinetics in some way or increased risk of toxicity because of altered concentrations. And the one that I'll call attention to here is insulin. So there was a recent study that looked at ambient temperatures and risk of hypoglycemia. It was looking at populations in the US and Taiwan, and it found that the risk of serious hypoglycemic events requiring emergency department visits or hospitalizations was 40% higher on extremely hot days as compared to those days where the heat index fell in the 25th to 75th percentile of those historical averages in the area. The authors here postulate that this is due to increases in insulin absorption secondary to vasodilation, which leads to hypoglycemia. And of course, this is purely observational, so we can't rule out other factors like changes in diet or potential impacts of temperature on accuracy of glucometers or anything like that. But it does suggest that the changes in insulin kinetics that might be brought on by extreme heat temperatures have real impacts on clinical outcomes that providers managing patients with diabetes should be aware of and should account for when we're looking at insulin management. Temperatures are also going to increase the risk of heat-related harms by impacting our thermoregulatory capacity or potentially exacerbating dehydration, electrolyte abnormalities, or other sequelae resulting from overheating. So thermoregulation can be altered through medication-related changes in our capacity for behavioral thermoregulation to get out of the hot environment by altering our mental status or impairing our heat avoidance behaviors. Medications can also impact our autonomic thermoregulation through impacts on our central thermoregulatory mechanisms. And that can impact cardiac output, impair peripheral vasodilation, it can impair our capacity to sweat, and it can increase endogenous thermogenesis. All of this also, we can see exacerbations of dehydration, electrolyte abnormalities, and that can happen through both direct fluid loss and changes to thirst perception. So there are a lot of different mechanisms in which drugs are impacting or somehow interfering with our mechanisms that we have in place to keep us cool and keep us safe during hot weather. And for the sake of this presentation, I'm not going to go into the details of all of the different medications, but I am going to try to give you a high overview of some of the common classes of medications to give you some practical pointers. The thing that I will point out here is if we look across all of this, these are very common medications, right? And so we do need to be concerned about them as we're thinking about clinical management. The World Health Organization lists these 11 classes of medications in their public health messaging regarding heat risk and medications. All of these are listed here with other as a category or a class that includes things I'll talk about on the next slide. There was a recent meta-analysis that looked at these 11 categories of medications to assess their effect on core temperatures in adults during heat stress. And they found only a subset of medications, particularly strong anticholinergics, non-selective beta blockers, adrenaline, and anti-Parkinson drugs, were consistently seen to raise core temperatures under heat stress. The others flagged in this messaging did not see the consistent effects. However, I do want to say, put a big asterisk next to these data here, that these studies were mostly young, healthy men under the age of 30, under exercise stress conditions with a single acute drug exposure, most focusing on temperatures for a relatively short period of time, between like 30 minutes to a few hours. So this isn't a good representation of what we see in real world with our high-risk patients. So good data to suggest what's going on maybe at a mechanistic level when we're looking at single drug exposure, not as useful when we're trying to apply it to an older adult who has multiple comorbidities and is on multiple medications that might be impacting their thermoregulation. That other category that I mentioned, I did just want to draw this out here to show you that these are also common medications, including medications that may be used over the counter and that we may not actually be aware of, including things like laxatives or NSAIDs or pseudoephedrine, or even herbals and supplements that are associated with diuresis. All of these things can kind of fly under the radar for patient risk. Patients may not be aware that it can impact thermoregulation. And all of these things can kind of play into increased risk during extreme heat events that clinicians should be aware of. An important medication class that I will call out here in the high-level overview of all of this is anticholinergic medications, or medications with anticholinergic effects. These impair thermoregulation in our central nervous system and peripherally through changing signaling in our sympathetic chain ganglia that impacts our ability to sweat. And this combination of central and peripheral effects might have some synergy in decreasing our thermoregulatory capacity. Really, really common drugs included in anticholinergic medications as a broad categorization. So things like antihistamines, drugs for urinary incontinence, antiemetics, tricyclic antidepressants, and so on. This list is here. You can see that these are all very commonly prescribed drugs, but not all medications with anticholinergic effects are created equal. Some have mild or low anticholinergic activity, while others are much more potent. And the difference comes down to how strongly a particular drug is blocking acetylcholine in the body and the brain, and how easily it can reach the brain in the first place. So the chart on the right shows relative anticholinergic effects, or the burden of some specific medications ranked by high, moderate, and low. These risks can compound with multiple anticholinergic medications in the context of polypharmacy, and especially when you're looking at the use of anticholinergic medications in older adults. We often use this as other medications that are high risk or potentially inappropriate in older adults anyway when we're categorizing these. And I would argue that in the assessment of heat risk, this is yet another reason to evaluate prescribing and deprescribing of these medications. Other important drug classes or broad categories include cardiovascular drugs and psychotropic drugs. These are some medication classes here, specific examples and the mechanisms by which they sensitize people to heat exposure or increase their risk of adverse effects from heat. A couple that I'll call out here that we see consistently in the literature when we're looking at kind of broad population-based studies, looking at hospital admissions or ED visits or mortality. Things like diuretics, ACE inhibitors and ARBs, and antipsychotics are frequently the ones that show the biggest signal in terms of association with heat exposure, medication use, and harm. So these are ones that I will call out, but all of these in theory have some impact on the body's ability to thermoregulate and should be things that clinicians are aware of as they're managing medication. And the truth is, right, that none of this is simple in the real world. Medications are not typically used alone in patients without other risk factors. They go hand in hand with age and chronic conditions and overlap with other risk factors. This means that this can also compound or potentially intersect with risks in populations that are like older adults or people with diabetes or Parkinson's disease or other people with reduced ability to make appropriate behavioral modifications in extreme heat events. So we think about this as kind of an overlapping composite with medications as an important consideration when we're assessing heat-related risk. One important population that I'll call out when we're thinking about compounding risks of medication use, other risk factors, and heat exposure is older adults. They face significantly elevated risks during hot weather for a number of different reasons, including changes in physiology across the lifespan, increasing medication burden, and multiple chronic conditions. Many of these medications that I previously mentioned have direct effects that are going to further compound the physiologic changes that make it more difficult for older adults to thermoregulate in the first place. And we see evidence of this in the literature. We see, kind of consistently older adults being populations that come to the fore in having higher rates of adverse events during extreme heat events. But there are also interesting studies, particularly this one published in 2020 looking at Medicare recipients, adults over the age of 65, taking heat sensitizing medications throughout the summer months. And they found that there was an increased risk of heat-related hospitalizations even outside of heat wave periods for people taking ACE inhibitors, ARBs, anticholinergic medications, antipsychotics, and loop diuretics. So all of those medications that I flagged earlier as being maybe potentially higher risk based on some of the broad population data studies we've looked at, we're seeing this in this one particular study, even outside of heat wave periods in older adults, kind of underscoring that they might be even more sensitive than we ultimately appreciate when we're thinking about their risks with medications. So in absence of really clear-cut evidence guiding specific prescribing recommendations for patients, we can lean on some general medication management principles, adding heat-related risk in our overall kind of risk-benefit analysis when we're prescribing and reviewing medications, and when we're doing individualized review and management of medications as part of heat action planning. And just as we should always be doing when prescribing medications, we should use the lowest effective dose for the shortest possible duration and consider additive risks across medication classes, thinking back to the previous slides that show all of the really common medications and how they all might have kind of overlapping impacts on our ability to thermoregulate. Considering that, avoiding polypharmacy, ideally avoiding prescribing unnecessary medications in the first place, and carefully deprescribing. Remember the risks of anticholinergic medications and the dual argument for just medication safety in general and deprescribing these medications, as they are often inappropriate just by fact of their increased risk for falls or cognitive decline, those sorts of risk factors as well. Ideally, we should also avoid initiating or making dose changes to medications immediately before or during hot weather events. Although this is really dependent on clinical judgment and individualized planning, and there's not good literature supporting specific protocols here. Bottom line, we should just make sure that we also are educating patients on how to protect themselves during the heat more generally, while also really including any specific medication guidance that we can provide, including having proactive and individualized plans for avoiding dehydration, particularly for those who are on diuretics or taking medications that might impact thirst, like ACE inhibitors or ARBs. These are going to be important things that we kind of have to take a multi-pronged approach to think about how we manage medications for hot weather. And of course, we shouldn't be doing this only in a silo, patient encounter by patient encounter. Yes, absolutely, that's important, but we should also be thinking at a systems level, the processes that are already in place, the opportunities that we have to integrate some of these evaluations of heat risk, these heat-informed prescribing practices into things like medication reviews or patient screening protocols, patient education planning, thinking about patient access, like for instance, planning for healthcare utilization increases during extreme heat events and patient outreach, but also maybe thinking about using pharmacies or pharmacists as access points for more regular patient contact to have a touch point before hot weather hits. Things like interprofessional practice are going to be really, really important here. Partnerships for public health planning, for developing effective clinical response protocols and guidelines, thinking about systematic approaches that we can take to medication management for heat adaptation. This is just one example. We can think about applying the same framework across lots of other climate resilience, climate adaptation efforts, but thinking about where this fits in the clinical protocols and pathways that we maybe already have or that we need to develop. I want to wrap this topic up by just really underscoring all of the limitations that we have in this area. The really global implications of the medication and heat interactions that I just discussed. Supply chain and last mile storage, we don't have good data around exactly how drugs are impacted the further they get away from things like central warehousing. This is, of course, impacting patient use, drug quality, and safety. And as I mentioned before, it plays into medication sustainability as well if we have heat-damaged medications that contribute to drug waste and subsequent environmental impacts because we've discarded them due to that heat damage. We need more research to really understand the true limits of heat stability of medications, of heat impacts on pharmacokinetics, developing heat-stable versions of essential medicines for low-resource settings. And also, I just really want to be clear about the limitations of our current research on medications and thermoregulation that limit the strength of clinical recommendations in this area. We have to rely a lot on clinical judgment and our best guesses in terms of some of the specific adjustments that we might make. So these are all general recommendations. I recommend looking closely, evaluating the risks, the benefits for your patients at an individual level. So let's bring this back to a systems level perspective to wrap this presentation up and hand it over to the case studies. So no matter where you are and what your role is, there's definitely a place to contribute to the efforts to mitigate the impacts of climate on our global medicine systems. And these are just a handful of examples of, production, supply chain, pharmacy and clinics, and patient use, things that we can do, whether it's vulnerability and readiness assessments in our pharmacies or our clinics, contingency planning, incorporating disaster planning and routine operation considerations of supply chain resilience, or even just that consistent patient education, thinking about how you might conduct outreach or think about individualized planning. All of these things are going to be important steps that we can take in improving medicine use in the context of climate change. I want to just call out, I know that these figures are completely impossible to read, but I want to call out a very recent publication in Lancet Planetary Health looking at a systems-based strategy for pharmaceutical pollution. And the reason I call this out is just I really loved the way that they articulated their approach to engaging different stakeholders and thinking about what are the systems drivers and impacts related to supply, use, and in this case, disposal and waste management around pharmaceutical pollution, and how do structures, goals, and culture shape visible and measurable outcomes. And then asking questions around how we can better understand systems to identify leverage points, co-benefits, and potential unintended consequences. So this is a recommended read really just because it is a great illustration of the complexities of the pharmaceutical system, as well as the ways that different stakeholders can potentially work together to improve the way that systems work. I would argue that this same approach could work in different contexts, even like adaptation to heat. So check it out, great read, I highly recommend. Because we have this complex global pharmaceutical system, it does mean that there are complex challenges, but I'll also point out that this means that there are many opportunities or points of potential intervention if we can align our efforts, if we can find the right leverage points, and we can collaborate across sectors to improve these systems. So you have a role no matter where you fall in this full pharmaceutical use spectrum. There are multiple stakeholders in this system, and I was so glad to learn that we had such a wide variety of participants represented in this course and engaged with these topics. We're going to need a combination of approaches, and I would imagine that those in the audience fall into at least one, if not more than one of the categories listed in the outside circle of this figure. So whether you are an educator or a healthcare professional, or maybe you are a leader in your facility, or you consult with government or regulatory agencies, or otherwise are involved in the pharmaceutical industry, meeting the goals for sustainable and resilient systems around our medicines is going to require a combination of approaches to promote innovation, regulation, transparency, investment, practice change, and to continue to promote education. So you're in the right place to continue to kind of help advance these goals. The bottom line here, climate-smart pharmaceutical systems and medicines use is an imperative for healthcare quality, safety, and equity. If we're going to move forward, we need to push for an expanded definition of what we consider rational use of medicines. As it's currently defined by the World Health Organization, it's the first piece of this quote here. Rational use of drugs requires that patients receive medications appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and their community. The new definition, as proposed in this publication from 2021, also asks that we maybe consider the interconnection between people, animals, plants, and their shared environment as a key criteria for defining something as being rational use. And I would agree, I encourage you all to continue to explore these pharmaceutical issues as they intersect with climate change. Learn more, find your role in the system, and enjoy the rest of this course. And thank you so much. Here's my contact information. Welcome for you to reach out to me. And with that, I will turn it over to my colleagues for case studies.
Thank you. Thank you very much, Hailey, for this wonderful presentation. I would pass now to Professor Fabrice Nayers for his presentation, and we'll have the discussion in the end with the questions and answers.
Thank you. I'll share my screen now. Thank you first, Anna, for the nice introduction. Let's see. So let me close that. Try to open the right thing. Just okay. It's okay. You can see my screen well.
Yes.
Okay, good. Thanks first for the invitation. And yeah, I will just present you very two simple example of case where the heat wave can have a big impact and how you can act easily to reduce the risks. And first, yes, I want to present myself. I come from Dijon. Dijon, it's located in Burgundy. It's in France. And here you can see some picture from my town, university, and around our university we have these very nice vineyards. And yes, as Ailey show you that already, the weather events will increase the temperature, the humidity, and that will directly have big consequences on medication, and it will alter efficiency, safety, and it will also reduce the half-life. And me today, I want to focus on a particular type of drug. Uh, I will focus on the protein-based drug. As you know, you have more and more drugs based on the protein, and we have very no example as insulin, but you also have more and more antibodies will be used, also enzymes. It's also very important to keep in mind that all these enzymes can also be used in, for example, when you record your glucose level using these strips. These strips are based with enzymes, and all these proteins have a structure, and the structure of the protein is directly linked to their function. And it's very important because the structure of the protein are much more sensitive to the heat compared to any other chemical drugs. And when a protein will lose its structure, it will directly lose its function. And then the extreme weather events will have two consequences. First, on the storage, as Ailey presents you that, you need to be very careful on the storage because as soon you have you broke, for example, the ice chain of the storage, you can destroy the structure. And when you destroy the structure of the protein, most of them will not recover the structure after the eating. When the structure is loose, in most of the cases, it's definitive. And you lose, of course, the function. And the second very important point is the using condition, because I will give you just right now a very simple example with the insulin. And now today, many patients are using insulin in pumps. And when you are using insulin in pumps, you load the insulin in pumps and it's directly worn with your body. It's exposed to your body temperature, but also exposed to the ambient temperature. And typically the reservoir temperature is around 30 degrees under the normal conditions. But when you have a heat waves, this temperature can increase to 37 or possibly to more, depending where you are and how intense is the heat wave. And consequently to that, some papers describe a reduced potency after increase of the temperature around 37. You can lose around 15 to 20% of the potency of the insulin. And consequently to that, it will increase the glycemic instability. And to prevent this overheating of the pump, you have some very simple advice you can directly provide to your patient. And this simple advice has to be communicated because most of the patients didn't have the knowledge and the insulin is the protein and has a structure. But if they avoid first direct sunlight exposure, keep the pump under closing, it will already have a huge impact to reduce the bad effect of these high temperature. And also some other advice like don't leave the pump in hot environment. If you move out the pump during your bath, for example, or in the sea, also be careful with the car. When the car is very hot, it can also have a big impact. And very simple also advice like to limit the exposure of your body to peak heat time hours with the temperature. And also, you can also give them some other advice like to replace the insulin more frequently during the heat waves. And of course, don't use the insulin when it was exposed to a high temperature like superior to 37. And also a very good point to keep in mind, if the patient can observe unexplained glycemia, and during these heat waves, you can suspect the insulin degradation, and you can advise them directly to change the insulin for a new one that they store in good condition. The key message will be when you have a doubt, change the insulin in this case. Insulin is not the only protein we use. Actually, we have a very increased use of this type of protein here, the glucagon-like peptide one, the GLP. And in labs, of course, you can't use that, but in labs, we have many techniques to evaluate the protein stability. And here on the screen, you can see a record we did in our lab. It's a record of the dichroic signal of the GLP. And this curve is very characteristic. Just to make that very simple, we use a light, a circular dichroic light, and we measure the absorption difference between a right and left circular dichroic light. When you do that on a protein sample, pure protein sample, as in this case for GLP, you can have a signal. This signal is very characteristic of each protein. Just if you are use of this type of technique, just by seeing this spectrum, you can recognize that this spectrum is a spectrum of GLP-1. And what is very interesting with that, you can't use that directly if you are GP or if you are a patient, of course, but in big hospitals, you can be equipped with this type of equipment. And it can be very good to use that also to have tools internally to the hospital to be able to record the stability of your protein. And by doing that, you can, if you have a doubt, you can test the sample and you can directly see if the sample was exposed to the big temperature would destroy the protein. And in terms of research, it's also very interesting because when you have this type of spectrum, for example, for GLP, it shows you that GLP is well structured. If you lose the structuration of GLP, you will have a flat signal. And this flat signal can indicate you directly that you lose the structure. And you can use also this tool in terms of research to try to reformulate the GLP formulation. And for example, we do that in collaboration with some pharma company to try to reformulate the GLP to have GLP formulation very more stable to the temperature. And that can be also a gain in the future to build up with the companies some new GLP formulation to have increased stability for the temperature. And we can imagine also to use some types of formulation for some country with other types for some other country, depending the risk of eating of each country. And that can be also a very good gain in the future, but it's just a beginning of the journey in this type of protein design, I will say, formulation. And in the second part of my talk, I want to share with you also some ideas and some also very preliminary results we have in the literature and we also have in the group. As you see during the short bio Anna do on me, I'm also very highly interested in the perception of the flavor in the mouth, and you can think what is the link with that, with with the temperature, what is the link with drug, but the link is very obvious. In fact, when you are using oral medication, it's very important for the patient the perception of the bitterness and the perception of the astringency. These two sensations are very important for the acceptability of the oral drugs. And we know that for some patients, as the kids or the old people, when the feeling is very bad in terms of flavor, patient can stop to use some medication or can reject some drugs. And that is very important for the observance of the medication. And just to give you some very few information about that, the bitterness perception is directly linked to receptors. In fact, you have 26 different receptors linked to the bitterness perception on the surface of your tongue. And for the astringency, I will give you a more deep presentation on that just after this slide. But just in a general manner, astringency is this dryness perception in the mouth. And these two feelings are very important for your acceptance of the medication. If I start with the bitterness, when you have a heat event, you will reduce your saliva volume, and by reducing this saliva volume, you have hyposalivation. You will also reduce the oral clearance, and because the bitter molecule will be less diluted, and because you are not able to clear the molecule as you will clear it in normal condition, you will increase the perceived intensity of the bitterness. It means that during the heat event, the perception of the bitterness will be more important, and this perception will be over compared to the normal temperature. If we look about the astringency, as I told you, the astringency is directly, it's a sensation of a dry mouth. It's a puckery sensation in the mouth, and it's very unpleasant sensation. You will have a direct rejection of this astringency perception. And I need also to add one very important point. Most of the drugs, most of the medication have a bitter, give you a bitter feeling, astringent feeling. And we try to design the oral medication to reduce this feeling. One very common way to reduce this feeling is to increase the sweetness. It's why in most of the drugs we add sweet molecule or artificial sweetener also, and the sweet will reduce this perception. It's one way. But in terms of during the heat wave, as I told you, the consequences will be different because it's increased the bitterness. And concerning the astringency, just to give you a very clear overview of the biochemical phenomenon underlying the perception of the astringency, on your mouth you have a very thin layer of water. On this thin layer of water is kept on the surface of your mouth thanks to some protein that we call mucin. And the mucin protein can keep the water. And what happens when you are eating estrogen compound? These estrogen compounds are able to interact with the mucin, and by interacting with the mucin, it will break this thin layer. And by breaking this thin layer, it will move out the water you will have on the surface of your mouth. And that will give you the sensation of astringency. And what happened during the heat wave? During the heat wave, you have less water. This layer of water is more thinner. And because of that, when you get an estrogen molecule on this thinner layer, it will promote the feeling of the astringency more intensely compared to a normal condition. Then, in the case of the astringency, as in the case of the bitterness, in both cases, the heat wave will increase this feeling. And which solution you can provide to your patient? First, it's very logic, I will say, and very simple is to stay well hydrated. And it's also very important to take medication with sufficient water. It's mean you can recommend the patient to avoid taking the medication when they already have a dry mouth. They can first hydrate themselves. Then, by having a good hydration when you take this medication, it will reduce the discomfort linked to the astringency and the bitterness. And also, you can think about formulation. It means during the summer when you have more risk of heat wave, when you have the choice, because it's not the case for all medication, but you can also think for some medication, don't use some types of formulation where the bitterness is very well perceived. You can change a formulation to have a formulation where it's less perceived. It can be a good recommendation for you during the summer time and during the heat wave. And also you can advise the patient to rinse the mouth after intake. It also can help to reduce the bitter compound in the mouth and reduce the discomfort. And of course, you can also advise them to avoid dry estrogen food, because astringency is a cumulative sensation. It means if you already eat, for example, estrogen food before to take the medication, it will also increase the estrogen perception when you will take the medication. And if you cumulate all the parameters that can increase the astringency as the heat wave plus the estrogen food, then the medication, the perception will be very bad. And it can be very simple and logical advice to give to the patient of that. And yes, and yeah, it's two examples I want to present you today. And thanks for your attention. And I will keep your question with Ailey. Thanks.
Thank you. Thank you very much, Professor Fabrice.
Stop my sharing.
Very good presentation. So now we have some time for answering some questions. And I would start by an interesting question to Professor Haley. There is a medical oncologist who is asking that his job almost consists of prescribing drugs. And he asks, where can he find more information about eco-friendly pharmaceutical companies? Where can he find information about climate-friendly ways of prescribing medication?
Yeah, thanks for that question. A couple of things I guess I would recommend, or I would just say upfront. In terms of being able to differentiate from medication to medication, one of the challenges that we face is that we often don't have good life cycle data for an individual drug. And even there can be a wide variation, even let's say you're prescribing the exact same drug and it's just two different manufacturers, there can actually be quite a bit of discrepancy between version A and version B of that same product. That's a challenge that people are working on right now to try to have more accurate analyses of the life cycle of the drug. You know, I gave you the example of the clonazepam tablet that traveled 60,000 kilometers to get to the point of use. Um, so in terms of saying, you know, is there a good place for a prescriber to look up and find the more eco-friendly option? That can be a bit challenging, just because we are flying in the dark, so to speak, in many ways there. In terms of more eco-friendly companies, you know, I won't recommend one over another. I will say that you often can look on the websites of individual companies and you'll see they have different commitments to environmental sustainability. You can look at their reports, you can see what they're doing. There's certainly movement in the industry to do everything from, you know, reduce emissions, convert toward more sustainable products, engage in recycling schemes of some of their you know, plastics in their packaging. For oncology, I think, you know, one of the biggest things, it's a huge source of waste in oncology. So from a green pharmacy perspective, probably the best thing that anybody in that space can do is working on reducing oncology medication waste. I know that that's a challenge often with vial sizes and drug shortages and trying to get the right treatment for the patient. But obviously, like the greenest medication is you know, no medication at all or the unwasted medication. So hopefully that is a helpful answer.
Thank you. The last thing you said was exactly what I was thinking. We have a lot of containers that accumulate because of the use of drugs. And this is my question. I was thinking about, do we have any data about the effects on environment about all these containers that we use for the drugs?
Yeah, I think that that's a growing area of awareness of the contributions to microplastics and other pollution and the realistic pathways for recycling for those containers. There's definitely been a push toward design of different packaging, better packaging, more biodegradable packaging by certain companies. And there's also been discussion around making purchasing decisions based on the packaging and thinking about your use in facilities and everything. That's going to be something when you think about like a systems approach, it's going to take everything from you know, the companies themselves committing to doing better with the packaging all the way through the choices that we make at the bedside in terms of the packaging or the particular product that we choose.
Right. Companies need to be responsible. That is a very important thing. Thank you very much. So I will go now to Professor Fabrice. There is here a question. Is the technology to test protein-based drugs readily available, especially monoclonal antibodies, which are extremely costly and whose efficacy can be compromised during global transport?
Yeah, for all these protein-based drugs, the efficiency will be compromised if they get hot temperature and if they lose the structure. And it's why in some hospital, like for example in our case, we have this device that allow us to measure if some of the pieces of these drugs we receive, if some are still active, because if they keep the structure. And this technology is not so easy to have available everywhere because you need this machine to measure the structuration, like the CD I show you. It's not so easy to have access. Yeah, if I can complete, I also see some question in the in the side of my screen. I have a very interesting question. Some people ask uh, which type of drink can be astringent or bitter. You have very easy example, for example, the tea or the coffee. And I will say, don't drink a coffee or a tea before to take your medication for this other side.
Okay, thank you very much. So there is also here an interesting question for Hailey regarding if there should be created recommendations about medications which will need dose adjustment according to the temperature, and these recommendations could be addressing general practitioners. So, do you think there should be these kind of recommendations? Would this be useful?
Yeah, I mean, I think that again, interpret all of this with caution or with your own best judgment right now, given the limitations in the data. But yeah, absolutely. And there are a few tools out there. One that I can recommend is the AmeriCares toolkit for frontline communities, climate resilience. That does have specific medication related overview, some tools for providers, some tools to discuss with patients. That again is just very general recommendations. Full disclosure, I was involved in helping develop that. But that is something that I think in general, just it would be great to have a more concerted effort to gather the right data, to be able to contribute to more refined prescribing recommendations, which drugs does it make sense to reduce the dose? Where does the risk versus the benefit kind of balance out in terms of treatment adjustment? What are the highest risk things that we really need to be aware of? Because as I said in my presentation, some of this we've actually studied core temperature. Usually those data we're studying younger, healthier people. A lot of the data we have to say these things harm, that are causing harm during heat. It's us looking at large data sets that may or may not give us the resolution to really translate down to detailed decision making at the prescriber side.
Yeah, thank you. As a cardiologist, I always think about antihypertensive drugs, which can cause vasodilation. And during periods of heat, patients get very hypotensive. Sometimes they faint and they don't drink enough water. They don't fulfill the cardiovascular system. So it's something that it's always important to say to the patients if the temperature increases too much, you need to be first to be hydrated, and second, maybe to reduce a little bit the dose in order that you don't feel bad. That is important too. So now, Professor Fabrice, there is here another interesting question from Ghana regarding if heat can affect the potency of oxytocin. The person who questions it says that sometimes after delivery, when inject oxytocin drugs, it takes time for placenta to be detached. And even if it does arresting hemorrhage, it can become a problem. So it's a lady who's asking this.
Yeah, I'm not specialist to answer specifically for that, of course, but yes, and as I can imagine, and Ailey also give you some very interesting information about that. You have many aspects. You have the stability of the drug, but you have also the when you use the drug, the pharmacokinetic of the drug in the body will be different following your hydration level, of course, depending also, yeah, the stress of the body, depending on the temperature. And for sure, I will answer yes, the temperature will have an impact on the oxytocin effect on the body. But What will be the main reason? I have no answer, but it's maybe a combination of different factors. As when I present you results on the insulin again, it's not only the stability of the insulin. Of course, the stability of the insulin in the pump is very important. You can play on that, but you have also the pharmacokinetic and all these different factors will be very important. And I guess you can keep that in mind for most of the drugs. And of course, when the drug is a protein and you need to preserve to keep the fold of the protein, that will be another very important aspect.
Yeah, yeah, extreme heat and extreme cold, they really affect metabolic status. So it's not only the drug that is stable or unstable, it's our response to the drug that might be
Yeah.
different. And we are almost in the end. I would like to ask Ellie, there is a question here that you mentioned practice change and education as key approaches. And the question is if you can tell us more about how to address this.
Yeah, I think that one of the big things is we just need to have kind of a united front together in thinking about how we integrate these into the clinical teaching, and these concepts need to be integrated into everything that we already teach rather than teaching as a separate topic. So connecting it to the cardiology unit, connecting it to the patient case, connecting it to, and starting to weave these themes throughout, saying, what is our approach to deprescribing for this patient and what is the sustainability benefit for this rather than treating these as separate topics. I guess that's my short answer. In addition to doing what you're doing right now, gathering the data, building up your foundation so that you can help disseminate this information out to your peers, to students, to other trainees. I guess Maggie put in the chat earlier, we are launching a pharmacy working group around trying to get more pharmacy education. And then, of course, that pharmacist-oriented education can be used by doctors, by nurses, by all manner of health professionals. So if you're interested in joining that, please check that link out and submit your interest in participating.
Okay, thank you very much. I think we are on time to close. If you have any important message to leave, both of you, please, now is the time. If not, I think I need to remind everybody about registering in part 2, which is really, really very important. So, Haley, Fabrice, shall we
I
say
just
goodbye?
want to say thanks, Anna, to manage that, and also thanks, Ailey. It was also a very nice presentation, and I guess we are very good in without discussing before to have a very good complementation, and thanks for that.
They were very complimentary, the
Yeah,
presentations. Very
without
good.
knowing
I enjoyed a
from
lot. I
one
learned a
side to
lot.
another from the earth.
Okay. So
Me, it's the
thank you.
evening, you, it's the morning. Good.
Thank you so much. Thank you for being
Thank you.
here and thank you for this whole session. Thank you. Bye bye to everybody.
Bye
Enjoy
to all the
the
earth.
rest of the day or the night. Bye bye. Thank you.
Bye.